Welcome everyone to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, you may enter your question into the chat. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Megan Joseph. Dr. Joseph is originally from Lakeland, Florida. She attended University of South Florida for her undergraduate degree and Lake Erie College of Medicine in Bradenton, Florida for her medical school. Dr. Joseph plans to specialize in nephrology and is currently applying for fellowships. Join me in welcoming Dr. Joseph.
Hello, everyone. Like you said, my name is Megan Joseph, and I'm going to be speaking today about renal denervation and its effects on resistant hypertension. So I don't have any financial disclosures. So the learning objectives that we're going to go through today really are, firstly, to define hypertension and resistant hypertension. Then we're going to identify current treatment modalities. We're going to describe new treatments of renal denervation, compare current treatment regimen to the new procedure and determine benefit and efficacy. And lastly, to apply knowledge to patient population to recommend appropriate treatment modalities. Similarly, there was a presentation outline defining hypertension, why we treat hypertension, current modalities, what is renal denervation and the trials that we have, the current trials, as well as comparing and contrasting treatments, and then lastly, just to add in treatments and how it can affect CKD patients. So what is hypertension? I'm sure we've all seen this lovely graph, generally defined as blood pressure greater than 130/80. A systolic blood pressure is when your arterial pressure, when your heart contracts, and or just diastolic blood pressure when your heart relaxes. So normal is less than 120 and systolic, and diastolic less than 80. Anything over that is considered elevated, and then hypertension greater than 130/80. What is hypertension and why do we care? Hypertension, as we know, is a silent killer, right? So not that patients feel it most of the time, but it is a major risk factor for stroke, coronary artery disease, heart failure, AFib, CKD, etc. Two main types of hypertension are primary or essential hypertension and then secondary hypertension. So 90 to 95% of cases are essential hypertension caused by nonspecific lifestyle and genetic factors, excess salt, excess body weight, smoking, physical inactivity, and alcohol use. And 5 to 10% are secondary risk factors. So just to touch on it, secondary hypertension, the things we know, OSA, renal vascular disease like RAS and FMD. We have polycystic kidney disease, most of the endocrine disorders, hyperaldosteronism, Cushing's disease, hypo and hyperthyroidism, as well as medication side effects, so NSAIDs, antidepressants. Really the pathophysiology, like I said, a lot of essential hypertension is really genetic and environmental influences. So defects in renal sodium homeostasis. So as we know, water follows salt. So when patients have salt retention, they will continue to have increased volume, extracellular volume, and that can cause increased cardiac output and hypertension. And then there's functional vasoconstriction as well as defects in the vascular smooth muscle, all of which cause increased total peripheral resistance and can increase and cause hypertension. So from there, what is resistant hypertension? So resistant hypertension really is blood pressure that remains above goal despite patients being on 3 antihypertensive medications at maximally tolerated doses, and one of those medications should be a diuretic. This shouldn't be pseudohypertension, so what we know as white coat syndrome. Also, patients who are non-adherent do not fall under the category of resistant hypertension. As far as its prevalence, approximately 10 to 30% of hypertensive patients have resistant hypertension, generally in older patients, as well as patients with CKD and obesity. So this is a good up-to-date flow chart of if you have a patient that comes into the office and they have high blood pressure, is just really to kind of determine does it fall under resistant hypertension. So the biggest things I think you can take from this, it might be not as clear, but is to confirm that their blood pressure is elevated outside of the office too. White coat syndrome is very real, so that those patients need to be having their blood pressure checked outside of the hospital, outside of the clinic or the hospital. As well as these are the recommendations for the 3 blood pressure medications that they should be on: long-acting calcium channel blocker, long-acting ACE or ARB, and then a diuretic like a thiazide. And then if they hit all of that, they can fall under resistant hypertension. So importance of treatment, we kind of mentioned. Resistant hypertension, just like regular hypertension, increases your risk of cardiovascular events, MIs, strokes, as well as chronic kidney disease and later ESRD. The current treatment limitations, so standard treatment, which I'll kind of go over, lifestyle modifications, medications, but patients still remain uncontrolled with these changes in treatment. So the highlights for the need for an alternative or an adjunctive therapy like renal denervation comes to mind. So the current treatment modalities, as we all know, lifestyle modification. So first thing, diet, we can cut out salt, less than 2.4 grams per day. We can increase physical activity. There's also weight management as well, getting patients under to a normal BMI, as well as alcohol moderation, so limiting alcohol intake. And then we do have some interventional treatments currently. So baroflux activation therapy, where we stimulate baroreceptors to modulate the blood pressure by decreasing sympathetic tone. But the limitations with that are it's a little invasive, it's cost and mixed efficacy results. They haven't had good treatment with that. And then the medications, this is what we know when we go to our first line treatments are ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics. We also have many other different diuretics, MRAs, beta blockers, vasodilators, loop diuretics, and clonidine, different treatments. So now to renal denervation. So this is the new treatment modality that we have been studying and going through. So basically it is a catheter-based intervention. They will place a catheter into the femoral artery and lead it into where the renal artery is. And the nerves that run next to the renal artery, they use ultrasound or radiofrequency treatment to ablate these nerves. And I'll kind of go into the pathophysiology of that. But the objective aim is to disrupt the overactive renal sympathetic nerves, which are believed to contribute to sustained high blood pressure and resistant hypertension, especially in those who've had hypertension for a long period of time. The procedure duration generally is 30 to 60 minutes. It's almost like a cath, very, very short. And then the technologies used start with radiofrequency ablation. It's most commonly, it was the first one that they used, but the technology has since advanced and we're starting to use ultrasound ablation that uses high frequency waves to achieve the same effect. And then also chemical ablation. So now they're starting to inject alcohol as well to ablate some of the nerves. So this is just a picture of what that looks like. So just like I said, they use a catheter to go through the fem to the renal arteries, and they'll ablate the nerves right there in the renal artery. So mechanism of action, so it's really the SNS role in hypertension. So the sympathetic nerves play a key role in regulating blood pressure as far as heart rate, vascular tone, and maintaining renal sodium. So when they're overactive, especially in the renal nerves, it can be a significant contributor to resistant hypertension. So in the renal artery, the renal nerves there can influence renin release, which increases blood pressure, as well as sodium retention and vasoconstriction of the artery. And then sympathetic overactivity, there's often overactive sympathetic drive in resistant hypertension, leading to sustained high blood pressure. So it's sort of a never-ending cycle. So in renal denervation, they're targeting the renal sympathetic nerves, reducing their activity. So you have decreased renin release, so lower renin levels result in reduced angiotensin II and aldosterone, leading to vasodilation and reduced sodium retention. You have reduced vasoconstriction, so you lower sympathetic outflow, vasoconstriction is diminished, and you contribute by reduction in peripheral resistance. And then lastly, improved sodium excretion. So you have decreased renal nerve activity, enhances sodium excretion, decreasing extracellular volume. So this is kind of a diagram that you can see. So really what you're cutting out is this, when you do the renal denervation, the afferent signaling that goes to the brain when patients have ischemia, hypoxia, oxidative stress, and then the efferent, so the renin release and RAS, all of that will decrease volume retention. And if it wasn't there, it would increase volume retention and increase blood pressure. As well as the other side of central sympathetic. So you have your alpha receptors that cause vasoconstriction, and then your beta receptors as well that increase cardiac contractility and output, all of these. And so RDN ideally will cut that out so that you wouldn't have the central sympathetic activity. So just to get into some of the trials, there is a lot of research that's being done in resistant hypertension and renal denervation. The first initial trials, so I'll touch on those: Simplicity Hypertension 1, Simplicity Hypertension 2, non-randomized and randomized trial. They showed significant reduction in blood pressure in patients with resistant hypertension. This is kind of what sparked the interest of this whole procedure. Based on these early results, it was quickly adopted in a lot of clinical settings, many believing it would revolutionize hypertension as we know it, pretty much. Then came Simplicity Hypertension 3, and this kind of threw a wrench into it. So this trial was a sham-controlled trial done to determine the safety of renal denervation. It was done through 2011 to 2014, the initial trial, but it kind of went on for another 36 months in total. So the significant difference in reduction of systolic blood pressure between renal denervation group and the control group was not significant in this trial. They used a radioablation procedure, not the ultrasound, so this was the Simplicity. They have their own technology that they use, this company. And this trial led to a lot more cautious approach in regarding to renal denervation. They were not getting the same results, and it was not showing significant changes. However, like I said, this is the longest trial that was done, and this went on for 36 months with the follow-up. So that actually did show that patients, though initially in the 6 months in the year, did not have changes in their blood pressure compared to the sham, the control group. They did, after 36 months, continue to have decreased blood pressure, checked with the 24-hour ambulatory blood pressure, indicating overall better blood pressure control over time. So this is some of the, just showing you the study populations for this trial, as well as you can see over there, really is, really is no difference in the denervation and the control group in their reduction of blood pressure medications. And as you can imagine, people who are on trial, in medical trials, they become automatically more consistent with their blood pressure medication taking. And so that could be the evidence that we see here. Then came the Radiance Hypertension Trio. So this is, again, treating patients with resistant hypertension using this technology. However, they started using a different catheter modality. So the catheter they use here was an ultrasound, and they were able to do it in multi-center single-blind sham-controlled trial. Actually, Piedmont here in Atlanta was also a part of this trial. So this shows you just the inclusion criteria. So a lot more men than women, which is generally common with hypertension in general, but they were having to have resistant hypertension, so having to be on 3 medications as well as thiazide. And that also is just showing the inclusion criteria. So in this trial, actually, there was, as you can kind of see in these graphs, was significant reduction in blood pressure. And especially 24 ambulatory blood pressure. So not necessarily the one time that they checked it in the office, but over 24 hours, they had significant reduction with the renal denervation compared to the control group. And it did show significant numbers. So similar to the other trial, the goal was to see the effectiveness and safety of renal denervation with the Paradise renal denervation system. So this is the ultrasound catheter. And this trial was done from 2017 to 2021, so more recent. And then the inclusion was blood pressure greater than 160 despite being on stable regimen. And it did show that it was effective in reducing systolic blood pressure in patients with treatment-resistant hypertension. So comparing the trials, Simplicity, the initial trial, employs radiofrequency energy to ablate renal sympathetic nerves, and the Radiance hypertension trio used a Paradise system, which uses ultrasound energy. So the differences in the trials, ultrasound versus radiofrequency, might have had a different efficacy and safety, as well, and you can see it in the blood pressure reduction. The differences between them as well, the study design, procedural execution, and patient populations can also be why these trials were different. Simplicity hypertension faced challenges and did not achieve the expected results, but the Radiance did. So limitations in current trials. There's many other trials that I didn't mention here. The other one worth mentioning is the spiral hypertension on and off trial. There was 2 separate trials. The on trial showed patients who, after renal denervation, maintained their blood pressure medications, and the off was that they came off of their blood pressure medications. Both were done at Stanford, and both showed significant results for renal denervation, and that they were improved even when they came off of their blood pressure medications entirely. So limitations in the current trials is the variability in response. Patients have different anatomical, physiological factors that make them poor candidates of renal denervation, leading to variable responses. There could be genetic differences, kind of we talked about. Essential hypertension is a lot of genetic factors. So the genetic difference in their sympathetic nervous system in total. There's inconsistent trial results, like I said. So Simplicity hypertension trio showed poor results, while the other ones afterward showed significant blood pressure reduction. This led to how patients were selected and the creation of newer devices. So the current guidelines still recommend medications because of the variability in results, but this may change in the next few years as the technology continues to advance. So this is just a comparison chart between medications, the current modality versus renal denervation. So efficacy, as far as medications, it's effective treatment. Trials have shown slight improvement with renal denervation, and it relies really on patient compliance. Renal denervation is comparable or slightly improved blood pressure reduction, and there's no issue with compliance. As far as the safety of medications, they're relatively safe. Obviously, patients can have side effects to medications, cough, angioedema, peripheral edema. But renal denervation, so far, there's fewer systemic symptoms, obviously, because it's just the ablation of the nerve. But there's the risk of the procedural complications. As far as cost, hypertension is a $50 billion year problem that costs so much money. And so there's a long-term cost of medications, and then managing side effects of these medications as well. As far as renal denervation, there's a high upfront cost for the procedure itself, but if patients no longer require blood pressure medications, it could be the most cost-effective treatment. And then as far as healthcare costs and impact, so with medications, it really doesn't change much. We'll just continue to manage medications. Risk of cardiac CV events with uncontrolled hypertension for those who are not controlled with medications. As far as renal denervation, there's potential reduction in costs associated with managing hypertensive complications like stroke and heart failure. If patients have their blood pressure controlled, likely we could see a significant decline in cardiovascular events. And then as far as patient preference, medications, we all know they don't like taking medications. So the pill burden and compliance of that, and then renal denervation, in their minds, it could be a lifelong treatment as far as not having to take anything and getting a one-time procedure. So how does this change our practice? So renal denervation can be a new treatment option for patients with resistant hypertension. Given the most recent trials that have shown that it is very effective, it's efficacious and safe, it could be something that is recommended to our patients. Compliance with medications is already difficult, so just eliminating pill burden for these patients can be beneficial. It can be used as an adjunctive therapy, so patients who get this procedure done and then continue to be on medications as well. But ideally, kind of showed in the Simplicity 36-month trial is that eventually the blood pressure continues to improve and they could come off of medications entirely. And so can it become a treatment option as well for essential hypertension? So patients who just are on 1 or 2 medications, but can we pull them off of medications entirely as well, is another thought and where a lot of the research is going now. And so just to add my nephrology piece into this, obviously CKD, we have so many patients with CKD, and CKD and hypertension go hand in hand. So high blood pressure is present in 4 out of 5 CKD patients. It works in a feedback loop. So uncontrolled hypertension worsens CKD and leading to ESRD. And as patients have CKD, it worsens their blood pressure control. The main concerns with this renal denervation in CKD patients is the potential procedural damage to the vessels. Obviously, we try to maintain as much renal tissue as possible. They're concerned about the vessel endothelium with the radioablation and with the ultrasound. But all of the studies so far have shown that the damaged endothelium recovers within a week and the arterial wall and soft tissue within 6 months. So it's been showing that it is not really going to cause any harm to the kidney. Further harm after the 6 months, usually they go back to where they were as far as their GFR. In patients with resistant hypertension, it's actually been shown those with elevated urinary albumin to creatinine ratios that they have a reduction in albuminuria after catheter-based renal denervation. So the accumulating evidence for this is that it's safe for CKD patients, and if this can be added on and help prevent ESRD and the need for dialysis later on. So in conclusion, renal denervation shows a lot of promise as a treatment for resistant hypertension. It offers an alternative for patients who do not respond to the conventional therapies, especially for patients who have exhausted all other options. Renal denervation could be considered as part of a comprehensive management plan. So like I said, they could get the treatment as well as now not needing 4 medications, but rather 1 or 2. The continued investigation is still needed to fully understand the long-term benefits. So far, they've only seen improvement after a long-term process, as well as figuring out the optimal patient selection and the cost effectiveness of RDN. And as well as seeing how this affects different groups. I kind of mentioned CKD and ESRD patients, but how does this affect heart failure patients or any other heart disease or liver disease or anything really, because all of those kind of are intertwined in hypertension. So at this time, RDN should be viewed as a complementary to rather than a replacement for medications and lifestyle interventions, but it can definitely be used as adjunct. These are my references. Thank you very much.
Thank you, Megan. It's a really good presentation. I have a question, like out of curiosity, since the Simplicity trial is happened for a while, right? Have you encountered any like a post-HOC study, like to reevaluate those patients, how their blood pressure is doing after so many years, since it's such a chronic condition?
The 36-month, so that trial I saw recently, it was in 2021,
right,
that the final results of that came out. So I haven't seen anything since then.
What about the 1 and 2, the Simplicity?
The other Simplicity trials, I haven't seen, but all of the data shows that it has, after some time, that it has been improving.
Okay, so is there no rebound, so they keep off
No,
medication?
no, there hasn't been any studies of rebound or
Okay.
shown data of rebound.
Thank you.
Thank you, Megan. I think that was awesome. And I don't really know if this is a question, just more of like a comment, but I'm just wondering, like in the acute setting, let's say like shock or something, how this, if someone went through this procedure, how it would like what their outcome would be, I guess, because their physiological response would be impaired.
Sure. Yeah, I mean, that's a super valid point. I imagine that there still is the other processes of like if somebody was in sepsis or something, right? Like the other processes still happen in the body, whether that's vasoconstriction or whatever it is. So it might have some effect, I could imagine, just because they're not having the sympathetic fibers where they're having any vasoconstriction to the renal artery. But yeah.
Thank you. This was a nice presentation as well. This might be too early, but do we have like data on the incidence of cardiovascular events and stroke with people that received RDN compared to?
In all of the trials, obviously, like I said, the longest one was 36 months. They haven't found any increased cardiovascular events because the procedure is very, I mean, it's invasive, obviously, it's a catheter, but they haven't shown any major cardiovascular events.
Well done, Megan. It was a very well-chosen topic, very relevant for internal medicine. And you presented it well. Good to have some exposure to these practice-changing studies, which kind of brings me my question. Do you have any real-world exposure, perception of the benefits? I don't know that I've had too many renal denervated patients that I've taken care of.
Yeah, I haven't had any actually, but it would be interesting to see for sure. But maybe in my next stage of life in fellowship, I'll see some CKD patients who've had the procedure, but no, I haven't.
And then the specialists that are performing this, is that radiology or who's performing this?
Generally vascular or sometimes interventional cardiology can do them as well. That's who was doing it at Piedmont actually.
Thank you, Dr. Joseph.
Thank you.